I do apologize for displacing him because he's a brilliant and kind and wonderful pediatrician. I want to talk about two things this afternoon. The first is about thyroid disease in ME. And one of the things I have to tell you is I do not believe that thyroid disease is the cause of ME. But you might get the opinion that it is from these slides. ME has been mentioned several times today, that if you really want to treat ME or any disease, you really need to treat it very early on to prevent chronic problems. Thyroid disease in ME, I believe, is essentially a chronic problem caused by central nervous system injury. So let's get on to what we're going to be talking about today. The one is progressive thyroid atrophy in ME patients. Now, the normal male volume of a thyroid is 14.9 to 24 cc's, and a female is 13 to 21 cc's. These are the Mayo Clinic guidelines, not mine. And they're conservative guidelines, and I spoke to the physician who published these, and he said this was developed from several hundred studies over many years, and they felt that this was the normal range. One of the things we do in all of our patients, which none of the other physicians that I've heard here today and most publications don't seem to do, and that is all of our statements are in consecutive patients. So we're not cherry picking. We're not saying if you take this patient and that patient over there, this is what you've got. This is what we've got from 153 consecutive patients. And these changes are progressive. Unfortunately, like most physicians who see ME patients, we rarely get to see them from the day they first fall ill. What is particularly of interest is if you look at the thyroid stimulating hormone, the FT3 and the T4 microsomal antibodies, these are the normal indicators of thyroid disease. This is what literally every physician, whether they're GP or internist, is going to do. You go in with a fatigue syndrome, they do a TSH, maybe a T4, T3, and they say, well, they're normal, so there's nothing wrong with your thyroid. They dispense with it. They forget thyroid ever existed. Some will do microsomal antibodies to see if there's autoimmune antibodies against his thyroid, and those come back, in most cases, totally normal. The parathyroid are 4 small glands which are embedded in the actual thyroid itself, and you can test for that, and you can also test for ionized calcium and phosphorus as well, and these all give some indication of thyroid and parathyroid function and dysfunction. Unfortunately, when you test an ME patient for these, or many thyroid people, they're all normal, so nothing goes on beyond that. This is the sort of block which tells a physician whether he should check further or not. It's fallacious. I say that there's atrophic changes in a large number of ME patients. I don't think it comes from the thyroid. In our studies, literally all of these patients have had SPECT changes, and the worst ones have had SPECT changes in the subcortical and brainstem areas. And if you look at the red slide, which is the female patient, 107 of the women and 46 were males. Of the 153 consecutive patients, 65% of the women had atrophic thyroids. Now, what is really interesting about this is only 23 were normal and 30% of the men were normal. And in the men, there was still 54% atrophic thyroids. Men had more hypertrophic thyroids, enlarged thyroids. Now, this is quite astounding because literally all of these people that we examined had normal serum thyroid indicators. The second thing I want to and the only way you can pick this up is to look at actual ultrasounds of the thyroid. Now, thyroid malignancy in ME patients. We mentioned this last year. I'm going to mention it again. We submitted a paper for publication, and it was accepted a year and a half ago, but it's never got published for want of normal controls. And we finally got the normal controls from the a university in Spain, and so it's being published on the 1st of June of this year. Thyroid malignancy is a very rare malignancy. It occurs in 1 to 15 people per 100,000. So it's not a common cancer. We're finding it in 6,000 per 100,000. Now, these are very radical patients, and this is 100 consecutive patients that we saw that we looked at for thyroid malignancy, again with ultrasound. Only one of them had abnormal serums. So the general population is 1 to 15 per 100,000, and we're finding it in 6,000 per 100,000. I mean, this is really quite astonishing. But if you stop there and you say, well, these people, something is causing the cancer of the thyroid, malignancy of thyroid. One of the interesting things in these 6 thyroids, we have 8 or 9 of them now. One of the interesting things is that one of the smallest malignancies, which was no bigger than 2 millimeters, which normally you don't do even a needle biopsy to, we did it because it was highly vascular. It had already spread at that small size, beyond the thyroid. What was important about all of these cancer patients? They all had substantial injury in the subcortical brain areas. And this is the area which controls hormonal control of the entire body. It may also, in part, control the autoimmune system. So 5 out of 6, all of the serums were normal, and 1 patient had elevated microsomal antibodies. All of them had ME. The 3 things that we found in all of these patients, which was rather curious, all of the thyroid malignancy had these major subcortical neurospec changes, and all of them had significant arthritic changes in the cervical spine. And you've heard ME patients saying how tired they are and they can hardly hold their head up. What holds the head up are the muscles. And if the muscles are very tired, and this is hypothetical, all of the weight then goes on the spinal bony structures. Only one of these patients had been a football player, and so you would expect it to have cervical changes. There again is a major increase over the last few years in Ontario of thyroid cancer, but we've not quite got up to 15 per 100,000. We've got 6,000 per 100,000. So there's something going on. We think it's coming from diffuse brain injury in the subcortical area. That's all I wanted to say about thyroid. The second is about our definition of ME. I consider ME historically and actually to be very different from chronic fatigue syndrome. And I just did this funny thing of if you'd really like to have ME and how you'd get it. Well, becoming a woman is helpful. I know Dan mentioned that the figures were more equal between men and women, but these were, again, 1,200 consecutive patients that we saw in my clinic in Ottawa, and 82% of them were women. Now, there may be a reason why men show up more commonly in Dan's figures, and that may be due to the insurance system. Everybody is insured in Ontario and Canada, and so there's equal access irrespective of whether the patient has money or not. I don't know if that's why there's a difference, but these are our figures. Choose a high exposure to repeat infectious job, healthcare or teaching. These represent the biggest single groups of our patients. Or simply be a mother with school-aged children. Repeatedly become severely exhausted, run down your immune system. We have a small but substantial group of students who have had repeat trauma and I believe have injured their blood-brain barrier, which was mentioned earlier today. And then any minor neurotropic virus is going to cause a diffuse injury of the brain. Finding yourself an epidemic ME disease is pretty difficult because the last major epidemic disease period was 1984 when the Lake Tahoe and the Canadian epidemics occurred. And it pretty well slowed down by 1997. It's still going on, but minor. And it was mentioned here yesterday that the difficulty of finding some children with ME in Scotland, and this may well be because of roughly the 20-year cycle in epidemics of ME. We're about due for a new one now, and it would be really useful if the physicians of the UK could be ready for it when it occurs. It's going to happen sometime in the next 5 or 6 years, maybe 10 years, but probably in the next 5 or 6 years. If you really want to fall ill with ME, obtain any immunization, or even better, series of immunization when you're exhausted, when you have a minor infectious disease, or within 30 days before going to the third world country for that much-needed holiday, or maybe going off to fight the Gulf War. This is a sure way of getting an ME-like disease, and we've seen it again and again and again, and some of our most severe cases are this group. You must never, if you're going on holidays, going to a third world country, have any immunization in the 30 days prior to going. By all means be immunized, but make sure it's 30 days before. Because if you're going on a holiday because you're exhausted, you're going off to Mexico or Africa, and you just go into your doctor and say, "Doc, shoot me up with everything you got. I'm going tomorrow to Kenya or someplace," you've got a good chance of coming down with an illness. I'll just skip this. Now, the 1988 and subsequent CDC definitions basically say if a physician finds anything wrong with the patient, any abnormal tests, any abnormal function of organs, then you don't have CFS. And by exclusion, most physicians finding the patient has nothing wrong means that the CFS patient can only have an imaginary illness, a psychoneurosis, a conversion history. You lose both ways. So if anything develops from your CFS or ME, it's not CFS. And if they don't find anything, and this has been mentioned by several speakers today, then you've got some psychological problem. This is an inherent problem in all of the CDC NIH definitions. The Holmes and the Fukuda-Strauss definitions all mentions forgetfulness, irritability, confusion, inability to concentrate, memory difficulty, sleep disturbance, and fatigue. These are classic findings in major depressive disease. So any psychiatrist seeing this can rightfully say, using the CDC definitions, that the patient has a psychiatric problem according to their criteria. So this is an inherent problem. And some people in the United States believe, correctly or falsely, that the people, certainly not Holmes, but maybe Fukuda and Strauss, believed that this was really a psychiatric disease and writ it up in this measure. But whether they did or not, I don't know. But they've certainly played into the hands of psychiatric medicine. Now, one of the interesting things, and I apologize, Dan, for treading on your territory here, but the '88 definition, which essentially has given rise to all of the CDC definitions, the London definitions, the definitions from Australia, and all subsequent definitions are basically children of the 1988 definition. And what these experts, who essentially had never seen ME patients missed in that Lake Tahoe definition, was number one, acute onset, a direct result of a rapidly contagious infectious disease, rapid less than 1 week incubation period, immediately diagnosably in the first week, and the long-term malignant potentials. None of these obvious criteria of the Lake Tahoe definitions at any time in '88 or subsequently were ever written in to the CDC definitions. So I've always questioned the validity of the CDC definitions for anything. What happens, though, if you want to apply for a grant as a physician today? You have to quote these definitions, and you have to say that your patients conform to this definition. Most of the definition are symptomatic. The physical findings that occurred in the 1988 definition are almost never seen in chronic ME patients. What is worse is in the 23 years since the 1988 CDC definition was written up, it hasn't allowed for any effective cure or treatment of ME or CFS. And what good is a definition unless it's going to help you treat and cure a patient? Now, we were asked by Dr. Ian Gibson to prepare a definition for ME, and that's in your folder. It's a little yellow booklet, and you can look at it at your own leisure. And essentially, ME has always been a clearly defined acute onset chronic illness with testable and measurable pathological features. And we've written up the definition in those terms. And CFS has always been a definition of a syndrome, not of a disease. And the essentials of a useful diagnostic criteria of any illness to be curable, most diseases must be diagnosed as close to onset as possible before chronic features develop. To be treatable, a disease definition must indicate treatable pathological and pathophysiological elements. The CDC definitions do not do this. All diseases are characterized by, as I mentioned earlier today, pain, decreased comfort, fatigue, swelling, change of color, temperature, things of that nature. These do not take you to any rational diagnosis. Even the concept of fatigue after effort doesn't. I'm 70 years old. I have no fatigue, but 2.5 months ago I tore a tendon in my left foot, and now when I walk a mile or two, I'm exhausted. Well, you can say that's not ME, but if I had it in both ankles, I bet I couldn't walk a block without being exhausted due to the pain. The fact that you get exhausted from any use, whether it's standing, walking, or mental activity, is not a good diagnostic criteria. You cannot test for it. You have to take the patient's word for it. And as Dr. Spites, as Nigel said, the physicians just aren't taking this as a criterion. They say, well, this is psychiatric, this is all sorts of things. It's not good enough. It's not that it doesn't happen. It's not good enough in medical terms. And so what we're saying is ME is different from chronic fatigue syndrome. ME is an acute onset biphasic epidemic or endemic disease. It's measurable, persistent, with a diffuse and vascular pathophysiology of the central nervous system. And you can see this in both the acute and chronic phases. I've had a lot of criticism from this definition. What if I don't have it? Then you've got CFS. I'm talking about ME. All ME patients have a measurable diffuse injury of the central nervous system, period. If they don't, it's not ME. It doesn't mean that you're not severely ill, but you would fit into the chronic fatigue syndrome group because they don't care about whether you've got a diffuse measurable changes in the brain. The most other secondary important thing is ME demonstrates variable peripheral autonomic irregularities, particularly sympathetic nervous system dysfunction at a vascular level, both centrally and peripherally, as well as other immune and other organ pathologies. But this diffuse injury, which I've mentioned, the brain and the sympathetic nervous system, is quite relevant. ME is measurable. It's a path of the central nervous system and peripheral vascular system. And you've seen today and yesterday slides demonstrating some aspects, but there are many of them, and we discussed them in this definition. The pain syndromes, in part, are definitely vascular, maybe entirely vascular, and posterior root and spinal cord dysregulations. And these, again, were shown today. What is most important is that ME is an endemic or an epidemic disease with an incubation period of 4 to 7 days. We wrote this up in the Clinical and Scientific Basis of ME CFS, our textbook from 1990. This would suggest that human herpes virus 6, which I know the Americans really believe in, which has an incubation period of 12 days, is not the cause. It may be apparent in this group of patients, as several viral antibody reactions are, but I do not personally believe that it fits into the category of the causative agent. The second persisting phase, you know, within 2 to 7, but certainly within 7 days, because these patients start to have a series of diagnosable problems. The patients will tell you these, and this we again clearly illustrate in our book. These are just some of the pain syndromes that are not always there, but if they are there, these are so dramatic in the first week after the initial infectious disease phase, if it does occur, is finished. So not all ME patients are apparent, but most of them are right at a very early stage. Now, with the exception of the neuropsychological testing, brain PET, Quig, and some clotting tests, all of these tests that we do that are mentioned in this booklet are free of charge in Canada. And this gives me an advantage to the physicians in the United Kingdom and the United States. Every patient that I see, I start off with a day-and-a-half history and physical. It takes me a day and a half. The first day to do the physical and the history, and the second half day to go over what I've written, because I type it all up. I give it to the patient to read as they go out, and they usually come with someone, and then they, if they still have any energy left, to look it over. And then I go back and I go over these things the second day so we get it right. So I have an incredible advantage, and that is I can test for everything that is available in Canada free of charge, and we do that. This doesn't make patient or the physicians very much money, because whether we see a patient and do a physical in half an hour or a day and a half, we're paid the same, unfortunately. These are some of the things that we use. The simple things such as a carotid and transcranial Doppler is absolutely a machine that doctors in the United States actually have in their offices in some instances. It's not an expensive piece of material, and you can find out if the person has a spasmodic disease causing brain injury. And you heard earlier today how migraine was a common finding in a lot of ME patients. And you can, the beauty of a transcranial Doppler, you can see, certainly in younger people under 35 and 40, unless they're very obese, you can actually see the arteries and you can see them working. They're mobile living units. They're not wire pipes. And you can actually see them in spasm. And sometimes they go into so much spasm, the actual blood to areas of the brain is cut off. And you know that something is causing that spasm and causing that ME. And you can actually do the patient when they're rested and then put them through an exercise program for a couple hours and see the spasm increase. So this is an inexpensive machine, and it's a great tool, because if you find a blockage, then you can go to the more expensive magnetic resonance arteriogram, an MRA, and you can do an MRA and MRI at the same time, so you get double for your money. But you can then see if you're actually got a real or a functional block. We routinely find ME patients or CFS patients with an actual major arterial obstruction in their brain, and this is what has caused their ME. Now, a lot of those people have clotting factor defects, and clotting factor defects will occur in 3 to 5% of the normal population. We're finding them in up to 10%. So that small group, you can actually treat, in some cases, quite easily and get them back to health, because what they have is they've got a clotting factor defect causing brain dysfunction. And the older they get, these seem to compound. Again, this is all discussed in our pamphlet. And I won't go through the others. To my knowledge, there's not a Quig brain imaging scan in the UK. These are essentially a computer-driven EEG, and they are a brilliant piece of equipment. Dr. Duffy from Harvard may not have been the inventor, but he certainly was the man that has developed this machine. I first saw them in California in 1987-88, and sent my first patients from Canada down to California. And they can provide a remarkable mapping facility of brain function. You can tie them in with neuropsychological testing. You can give the patient physical and intellectual tests to do while they're on this machine, and you can see function and dysfunction of the brain. And when you see destruction of the brain area, diffuse destruction of, for instance, the left anterior parietal area of the brain, which is very important in visual and auditory connections. We've actually seen patients grow back the area in the posterior right parietal 10 or 15 years later, in which the functions that used to occur here now occur back here. So it's a wonderful machine to understand what's going on. None of these tests are important in themselves. What is important is a battery of these tests. And what I'm essentially saying is, you've heard some brilliant speakers today and yesterday, and I'm in stark amazement of some of these people, because they are brilliant and what they're saying is great. And you have to look at ME, as you do all diseases. There's a precondition. It may be genetic. It may be things that have happened to you as a child. There's an instigating cause. And a lot of these people are working on some of these aspects. Then there is a transmission. There's an injury. Then there's a transmission of this injury through chemical or hormonal or sympathetic or parasympathetic directions. And then there's an end organ injury. When we're talking about the thyroid, this is an end organ injury. So ME is a chronic total body disease, and you can approach it from any area. But once you have one area, it's easier to work backwards and forward to, if you want to understand the entire disease syndrome. Neuropsychological testing, it's very important, because and as I mentioned yesterday, the insurance companies use it to prove that the patient is not ill and is shirking. And so I use it first only to get there before the neuropsychologist, but it's a much more valuable tool if you can give the neuropsychological, the PET, SPECT information, the Quig information, which will tell them what areas of the brain are actually injured, and then they can do specific testing to support that. We've mentioned today cardiac abnormalities. There are tremendous cardiac abnormalities. Most of them are not coronary, as was mentioned again today. A lot of them, for instance, if you do a 24-hour Holter monitor, One of the speakers today, or two of them, mentioned the tachycardia which occurs in ME patients. Actually, if you do a 24-hour Holter monitor, which measures the actual heart rate over a period of 24 hours, and the computer is set up so you can tell what the heart rate is while they're awake and what it is when they're asleep, you get a lot more information. And what you find in this group of people, tachycardia to a cardiologist is over 100 beats per minute. If you do a Holter monitor, you get 88. They're going to say, well, this patient doesn't have tachycardia, but it's much higher than a normal person. But if you split it, what you'll find is that often the daytime heart rate is 112, and at nighttime it may be, while they're sleeping, as low as 40, which is pathological. This is sympathetic and parasympathetic systems clicking in again. So you have to not just do a test, you have to understand the pathophysiological basis of each test you're doing and put them together in a constructive way. I was very interested. Well, I'll finish up now then. So the autonomic nervous testing and POTS, again, we don't have enough in the way of internists in the United Kingdom who have access to this type of equipment and the funding, again, to feed these types of clinics. Funding is increasingly a problem in medicine. Some of the autonomic nervous system things I'd like to finish up with. The Raynaud's phenomenon, you see, this is the cold hands and cold feet, which occur in most women and a lot of small men, but it's much more severe. The circulating blood volume decreases. Acquired Ehlers-Danlos syndrome is a totally different thing, and I may be the only person in the world that believes this. I think a lot of people have potential Ehlers-Danlos syndrome, but I think it is also turned on. It's a gene disease. It's a genetic abnormality, and I think it can be turned on by certain viruses, and I have no proof of that. But a lot of these people are totally normal until they have a viral infection, and bang, then all the aspects of Ehlers-Danlos syndrome occur. The multiple medication adverse effect is a classical autonomic nervous system dysfunction showing up in vascular pathology. And by pathology, I mean pathophysiological. One of the things that I've seen literally 3 or 4 patients in England is diabetes insipidus, like bladder dysfunction, in which they are drinking all the time, but they don't have real classic POTS, and they don't have real classic diabetes insipidus, but they certainly have something in between. And I'm going to end up with the abnormal blood clotting factors. All of this is in our pamphlet, and you can read it. The hormone defects, the treatment. You have to treat ME like all disease. You have to get it right away. And this is why the CDC definitions of 6 months are not only foolish, they're anti all our knowledge in medicine. We've actually nearly, I've seriously injured a patient, head of nursing at the University of Ottawa, because she insisted on the graded exercise therapy program. We put her in the physiotherapy hospital, which is a great hospital. We put her through a 2 months program. She was ill when she went in. She's been bedridden for the 15 years since. We did that. With her help, of course, but we did it, and I'll never get into this type of treatment again. I'd like to thank you very much.